Oh gosh, okay. Um, uh, so photographs I'll be using are from my local services, but they're pretty generic, hopefully for services across the UK. And then I'll talk a little bit about the work that we do, particularly around kind of decision making and advanced care planning, because often that's the bit that most people are worried about, and probably one of the main reasons why people refer children to palliative care services. Thank you, Abby. Next slide. So children's palliative care is really defined by the RCPCH and then adopted by the World Health Organization as care that focuses on enhancing the quality of health and life for the child and the family. And really, I suppose what we should put here is a rider that really we're doing this in a context where the child's underlying condition cannot be cured, and it's likely that the child's condition is going to be progressive. But within those constraints, that we still be looking at how to enhance the quality of life, not just for the child, but for the family also. It's a total holistic approach to care that includes considering what practical support they might need. And that's often the most difficult, actually. The symptom management, often I put that last on the list because that's often the easiest thing for us to manage, is the symptom management. It's all the other stuff that goes alongside caring for this child that becomes very difficult, and often not the domain of medical services, but are things that we need to consider as well. So practical support, particularly if the family's got other children, can be very difficult to manage other children and meeting their needs, as well as a very complex child with medical needs at home. The emotional and bereavement support for the family and possibly the wider family as well. Spiritual care that may or may not again, sort of come into the realm of medical services, but it's something that we often ask about. The social support for the family, and that might be informal social support, or they might require more formal referrals to social services and children's services. Symptom management, like I say, and symptom management is often a balance. It's a balance between trying to manage the symptoms perfectly versus the side effects of the medications. And we'll come to that later on. The other big difference where children's palliative care differs from adult palliative care really is that often we deliver children's palliative care alongside life prolonging treatment, and particularly that's over the last 5 years that's been much more of a balance and sometimes a struggle for us, particularly with the very easy access to home ventilation that we have nowadays, and often we're managing. I've been managing a dying child for the last 3 years who is on a home ventilator. So that's quite tough because it's pretty tough to die if you've got a home ventilator. So that's a real challenge. But actually, that's what our work is like now. Thank you, Abby. Next slide. The other difference with adult palliative care services is that often children with life-limiting disease, it's something that you know from the point of diagnosis, and it can be very many years before the child actually dies that you know this child is going to need palliative care services. So it may be that they don't need specialist tertiary palliative care, but they need some support in managing a child with a progressive disease that you know that where the child's going to die in childhood. So actually we accept, or at least we consider, a child's referral from the point of diagnosis, and like I say, that can be many months if not years from the point to the point where the child actually dies. So children can be on our caseload for a long time. The children often will go through some kind of stable phase, and in which case the palliative care services that they might need would require, it will include respite care, psychosocial support, and maybe some symptom management. And most often that's around kind of chronic pain management that I get asked to intervene with. They might need some extra palliative care support during acute deterioration, because sometimes you just don't know if this is the deterioration where the child might die, or whether the child might actually survive this particular episode. And that time of uncertainty can be very difficult, both for the physician as well as for the family. And then around end of life care planning and the choices for the family. We often also then, at least if we don't deliver, then we identify what bereavement support the family is receiving or might need. Thank you, Abby. Next slide. Broadly speaking, 4 main groups of children who may need palliative care. Some groups are more prominent than others on my caseload. Category 1, these children have life-threatening conditions from which curative treatment may be feasible but can fail. And typically, these are children with cancer. So really, they only come to me or get referred to me if maybe the first line or second line treatments have failed. There may still be some curative options on the table, but often the chances of cure are diminishing. The other groups of children are children awaiting transplants, where you don't know if they'll make the transplant, or children with hypoplastic left heart, for example, that might be more complex than what might be a kind of considered good prognosis hypoplastic left heart disease. So these children often don't stay on my caseload for very long, because they often declare themselves quite quickly, but they form a large group of referrals. So over the course of the year, probably 30 to 40% of deaths that I manage belong to category 1. Category 2 is becoming ever more infrequent, as both as referrals as well as a category of a disease where they die from on my caseload. So conditions where premature death is inevitable, and conditions such as cystic fibrosis and Duchenne's muscular dystrophy. And you'll know that, so for example, when I was in medical school 25 years ago, patients died in the pediatric age group with cystic fibrosis and Duchenne's muscular dystrophy. Well, they don't anymore. Over the last 5 or 6 years, I've had one patient with DMD who died in the pediatric age group. The rest all died after transition to adult services. And I've had 2 patients die at the age of 18, cystic fibrosis. Everyone else died. I mean, and they really had already transitioned to adult services. So really, those conditions are becoming increasingly rare. The condition that used to make this list was HIV, HIV/AIDS, and that just isn't there anymore, because they all survived. Really, we're just so good at delivering care to postpone the premature death in these conditions, and that's particularly with the development of long-term ventilation technology in the homes. SMA type 1 is the other condition in this category, but as many of you I'm sure will know, there are actually many novel treatments now being developed for SMA type 1, and also with home ventilation, this group of children is surviving beyond the 1 to 2 year prognosis that we used to give them. So that group is an interesting group of children. Category 3 are patients that are probably making up the other very large part of my caseload, children where they've got very progressive conditions, and that's often the neurometabolic conditions where there are really no curative treatments. And then category 4 are children with cerebral palsy, really. So it's a non-progressive condition, but they have severe disability, where they're very vulnerable to complications and a premature death. So again, that sort of children are a significant part of my caseload too. Thank you. Next slide. And just to give you an idea of numbers, in an average health district most health districts, so for example, Southampton as a city, Portsmouth as a city, North Hampshire, so kind of half of Hampshire, for example, will have a population of about 250,000, and in that kind of health district or CCG, 8 will die from a life-limiting condition every year, and about half of that will be children with cancer. So those are the kind of numbers that I'm managing. So in the Southampton tertiary service, where we serve the whole of Wessex, so that's all of Wiltshire, Hampshire, Dorset, West Sussex, we probably manage between 70 and 80 deaths a year. Thank you. So we work very closely, really. So I just serve the kind of, I sit within that kind of top clog, but really we have to work with all the other services because palliative care is such a broad-ranging set of services that have to input into the family. So really quite critical are the community nurses that might either sit within primary or secondary care services. So they're very important, as well as the child's lead pediatrician in the local hospital. Thank you. Next slide. I just want to talk a little bit about hospice care. We're very lucky in the UK in that we've got a number of children's hospices, and most children can access a hospice within about an hour of where they live. And again, children's hospice is very different from an adult hospice. If you ever get a chance to go visit one, please do. Particularly if you're London based, there are several hospices in London, and some of them, it's difficult now with pandemic situation going on, but certainly I used to work in London, and we would welcome trainees to kind of come in and visit, particularly if the doctor is going to be visiting a hospice. So if you ever get a chance to go and visit, go, because it's very different from what you expect, and it's very different from an adult hospice. So these pictures are from Naomi House. That's where I work at the moment. And what we do, 90% of the work we do actually is respite care, rather than necessarily end-of-life care. So 90% of the work we do is respite, and at Naomi House anyway, we offer 60 nights a year to families. It doesn't matter what the condition is, we all just do a blanket offer of 16 nights a year, all charitably funded, so not a cent from the NHS or from social care, and for certainly families do not have to pay for anything. And really just families can stay with the child, or currently in pandemic situation they can't, so we'll take the child and the family can go home and have a rest, but in normal services, the family can stay at the hospice with the child. And it really just allows parents to be parents rather than to be 24/7 carers. It certainly gives parents time with the siblings without having their care duties for this, for the medically complex child. Like I say at Naomi House, they're entitled 16 nights a year, but it varies very, very widely from hospice to hospice. There are some hospices that offer 6 nights a year, so it really depends what your local hospice can offer. But the other aspect as well is every hospice, or at least every hospice I've ever been in contact with, have offered really good family support. So that includes counselling, and whether it's pre-bereavement or post-bereavement counselling for the family, sibling care, and certainly at Naomi House we've got a social worker as well, and then often there's a chaplain as well. So quite comprehensive family support services that you may not be able to access elsewhere. So we do get quite a few referrals where they say we don't need the respite, but we really like the family support, and we will accept that too. Thank you, Abby. We do provide end-of-life care. And certainly that becomes an alternative to being at home or in hospital. And all the hospices are staffed with pediatric trained nurses, so pediatric nurses, as well as with carers. Some hospices will have a children's palliative care consultant, some don't, but most hospices will have medical support from a senior doctor. That may well just be a GP rather than a pediatrician, but often the GPs will be very experienced in palliative care management. So there usually are senior doctors at a hospice supporting the nurses. So they all tend to be nursing-led teams, though, but often end-of-life care, what they really need is very high-quality nursing. And then, like I said, all the hospices will offer care following the bereavement of the child and care of the family. Thank you, Abby. Next slide. We also are very concerned about making sure that the psychosocial support is there for the patient, particularly the more cognitive patients. And often the hospice, especially if the parents don't come and stay with them and they're there for the respite, it's really a chance for the child to develop some independence. So I have a thing where if the child is age 30 and above and they don't have a cognitive impairment, I will ask them to tell me about their medication. So I will take their drug history from the patient, not the parent. It's part of preparing them for transition, but also it's about making sure that they have some idea of what their condition is, what their drugs are, and that just fosters this idea that they should have some independence, take some control, and have some aspirations, really. And these patients often can achieve a lot more than what most people in society expect of them. I mean, we've had several patients with the different kind of muscular conditions, particularly who go to university. And we've got a lad at the moment who is doing a PhD at Cambridge. So, with the proper support, actually, many of these aspirations can be fulfilled. We do often join up with other groups such as Action Duchenne's, and particularly around preparing patients for transition, and obviously some specific psychological support for families as well. Thank you. Next slide. There is also, I mean, if there was ever a study to make the case for palliative care and the impact of what palliative care can do for a patient, it's this one. It's done, well, it's 10 years old now, but has been replicated, actually, although this study is very elegant if you've never heard of it. Published in New England Journal of Medicine, done in the United States, actually done in Boston, where they looked at 151 patients with newly diagnosed stage 4. So this was all in adults, and we have to extrapolate and assume the same applies to children, but it really highlights a few important points that we can learn. So 151 patients with newly diagnosed stage 4 non-small cell lung cancer, and you'll know that stage 4 non-small cell lung cancer is fatal, whatever oncology treatment you might throw at them. So these patients were randomized to having standard oncology care plus early palliative care, or the control arm was just standard oncology care. The data that they looked at was the patients had to complete a quality of life assessment, so it was an objective assessment, as well as the HADS scale, the Hospital Anxiety and Depression Scale, and did that at the start, and 3 months later at 12 weeks, and they also looked at some end-of-life data. Next slide, please. The palliative care input really consisted of an assessment of the patient's physical and psychosocial needs, establishing goals of care, so really finding out what was important for the patient, what we wanted to achieve, and support with decision making with regards to ongoing oncological treatment, if they wanted to go for another round of chemo, for example. and helping to coordinate the care on the basis of the individual needs of the patient. Next slide, please. And what we found is that patients who received both palliative care and oncology care reported that they had higher quality of life, so they scored higher on that scale. They reported fewer depressive symptoms. The anxiety symptoms were the same, because most of them express anxiety around dying and what that might be like. So that was the same whether or not you had palliative care input. But what they found is that fewer patients in this group chose to carry on aggressive oncological treatment. So by the time they got to the end of life phase, there was a third fewer patients in the palliative care group who chose to receive oncological treatment. Next slide, please. But what we found is that despite, go back one slide, because the last line appeared. So, but what we found is that patients in the palliative care group, despite receiving fewer patients receiving aggressive oncological treatment at the end of life, they survived longer. They survived 11.6 months versus, they survived 30% longer versus 8.9 months. So I don't know what palliative care did for them that was so amazing, but it did more than oncological treatment. Either that or oncological treatment is really bad for you at the end of life. And I suspect it's both of those things. Oh, I always tell I hope there are no oncologists amongst us. I'll tell you a really naughty oncology joke. And this is, you know why we have to nail the coffin shut? It's to stop the oncologists from giving any more chemo. Okay, so chemo at the end of your life, really bad for you. Don't tell the oncologists know I tell this joke all the time. I think they don't know, but actually I think they know. Anyway, the other thing I would highly recommend to you, if you haven't yet gone on to this, is, no talk is complete without a quote from Professor Atul Gawande. If you haven't yet listened to the BBC Reith lectures, it's 6 years old now, in 2014, go and listen to them, entitled The Future of Medicine, given by Atul Gawande. An absolutely brilliant series of about four lectures. And in one of them, he addresses this idea of aging and dying. And one of the things that he says very eloquently is that we as healthcare professionals, the most important that we fail to understand is that people have priorities besides just living longer. The second most important thing that we fail to understand is that the most powerful way to learn about what those priorities are that people have is to ask them. And very often we don't. And that's the reason people have to fear. And that is incredibly true. So, I often start my conversation with families just asking them to tell me about their child. Even if I see a child on the intensive care unit, usually the first question I ask the family, after introducing myself, is tell me what little Maggie is like when she's well, or tell me what Rachel is like when she's well. I don't ask them about the disease, I just ask them about what their child is like. And then that makes the conversation a lot easier. But also that really starts to tell you what is important to their child and what it is they treasure about their child. And then that really starts to flesh out what the priorities are people have. And then we can go on and talk about the disease later on. Thank you. Next slide. So the steps that we try and do is to try and clarify some goals of care and priorities for patients. So I talk about goals of care all the time, especially with my colleagues who want to give more treatment or different course of treatment. And I kind of go, okay, but what is the aim of the treatment? What are our goals here? Goals and priorities will change as the disease progresses. When speaking to families, then presenting what the care options or treatment options are in an open, balanced way is very important. And acknowledging the burdens of treatment and side effects as well as the potential benefits. And that's both in terms of the disease-directed treatments as well as the symptom management treatments. So I will often, right at the start, before I start the morphine, really kind of be clear about the side effects of the morphine or the oxycodone or the midazolam, just so people understand early on that what we're trying to do really is to balance pain relief versus the sedative effects of the treatment, and to talk about how actually maybe the symptom management won't be perfect because it may be better that we have to put up with a little bit of pain for the child to be awake. There might come a time where actually we will accept the child to be asleep, to be more sleepy, but be entirely pain-free. So just to be really open and balanced right from the start. Thanks, Abby. Next slide. Next slide. Thank you. Oops, we skipped one, I think. Fabulous. Oh, this is just a really an idea to tell you what kind of decision-making treatments that we do all the time. So really around decision to proceed with radiotherapy or experimental therapy, for example, particular ones around incurable brainstem tumors, so the diffuse intrinsic pontine gliomas, where we manage about 5 a year at Southampton, which is a lot, I think. And that's often difficult. Whether or not we should be going for scoliosis surgery. So we discuss a whole group of patients every month around that. And then all the considerations around innovative therapies, and of course cannabinoids is often the one that all the parents will ask about. And all of them will be on some form of cannabinoid that they've got on the internet. But I've made my peace with that. If it's not causing any harm, then if they want to give it. I'm not too fussed. Thanks, Abby. So the important points, I thought I would talk for about 5-10 minutes around advanced care planning. There's just a lot of listening. So again, that whole thing around how we should be spending 70% of our time listening, not talking, applies really. And for me, I have to really be conscious of it and pay attention to how I'm listening, how much I'm listening versus how much I'm talking. And I've done palliative care for 10, 11 years now, and I still talk too much. So listening, very important. And what I'm listening out for are words around kind of expectations and hopes and fears. And those are the things that I really want to know. Often around kind of advanced care planning, we don't do it in one sitting. We often have to do it over several meetings, or even several informal chats. You do need good pediatric knowledge, and sometimes, as I said before, the care that they need, particularly around the end of life, is just good pediatric nursing, as much more than the medical bits. But having said that, good pediatric nursing can be very difficult to deliver, particularly in the child's home. Just trying to ensure that the child can have access to 24/7 community nursing support can be very challenging because of our nursing shortage. Teamwork is critical, and don't forget that actually we're doing all of this for the child and not just for the family. Thanks, Abby. Next slide. There are lots of barriers to discussions, and again, this is something I have to be conscious for myself. sometimes it's just really difficult because you're not sure that the parents want to have these conversations around resuscitation orders or end of life care planning. It is much easier to talk about the next Make-A-Wish, plan, or you kind of you want to try and sound a bit more optimistic and hope that they're going to be stable. But very often, actually, the kind of worries that we have when we're thinking, oh, we better start talking about this, parents also share. Often, what I find is that parents will admit later on that actually I have been worried about this for a while, but I didn't want to be the one to raise it because it just sounds like I'm giving up hope. And having someone else raise the fact that this would be a good idea, that we need to do this, is really important. And I think to some extent, I think parents and the public and society at large have a high expectation that we will continue treatment to prolong life. But it's about trying to inform the family what life-prolonging treatment really means, what intensive care support really means. Intensive care support is really not feasible. It's futile if you cannot cure the underlying condition, or you cannot improve the underlying condition. Context can be difficult because it can be difficult to raise these issues when the child is well. And then there is just kind of whether, whether I can do this, whether or not I'm going to get flustered. And the key is to understand that everyone gets flustered. It doesn't matter. I've done this 11 years. I sometimes still get flustered. So it doesn't matter, because the parent is, just remember, the parent is a lot more nervous and a lot more emotional than you are when we're talking about these things. Thank you, Abby. Next slide. What I do try and keep in mind are the next couple of slides. This one, where they interviewed 41 parents who've died on intensive care unit, and they asked the parents what was important to them when deciding about withholding or withdrawing life-sustaining treatment. And those were the 4 clear things that parents really valued and were important to them. The doctor's recommendation. So we have to come into these conversations with a clear recommendation of what is appropriate treatment for the child. Do not just ask the family, so do you want us to take your child to intensive care? That's not how it works. It's not the family who get to decide, not unilaterally anyway. You need to come in there with a clear recommendation. I do not think that little Annie should go to intensive care if she has another Pseudomonas chest infection, because. And the family might disagree, and that's fine, but you've started the conversation and you've made a clear recommendation with a clear reason. And if they've got other reasons about why they feel little Annie should go to intensive care, then that's fine. And they may well be right. And you may well kind of go, okay, we'll go with your, certainly for the next time, with next Pseudomonas chest infection, we'll go to intensive care. But at least you've made your recommendation. And if they disagree with it, they disagree with it. But it's our responsibility to go into this with a recommendation and not to put the entire responsibility of the decision on the family. The child's underlying diagnosis is very important, because often the parents may already have some expectation that ongoing life-sustaining treatment is not viable. The degree of neurological recovery, or the degree of neurological impairment is going to be very important, and that's often one of the reasons that parents will say resuscitation is not a good idea for their child, because if the child then has another hypoxic brain injury because of the arrest, then the neurological recovery will be very poor. And the degree of pain and suffering that they perceive their child to be under, that's again kind of incredibly powerful for the family. Thank you. Next slide, Abby. And then these are the things that parents find really important at the end of life. So this is what I try and reassure families that will happen if we have a clear end of life plan, that they will get honest and complete information, that they have easy access to professionals to ask questions, to clarify plans if they change their mind about a plan, for example, or if the child's condition changes and they want to clarify further bits of information. They often will prefer a professional who's familiar with them and has had a previous conversation. So particularly on an intensive care unit where people change shifts all the time and the consultants change over from week to week to week. And certainly at Southampton, what we've done is that if a PICU consultant has started these conversations with the family, then that particular consultant will see the conversation through, even if it's the following week or the following week. Rather than to have a change of professional. And that's just around coordinating the care and communication, because what families don't want is to repeat the conversation over and over again. So certainly as a junior doctor or registrar coming over, taking over a shift, what the families don't want is to then have to explain it again to the night shift, for example. Families really appreciate an emotional expression and support by staff. So actually families view, so if you shed a little tear and you have a little cry, families actually view that not as weakness, but that you really care for the child. And I've had some families say that to me, and they've said, we know that you really care for Chloe, or you really cared about Chloe because we saw you shed a little tear when you talked to us about her end of life care. And I will often say to our juniors that it's okay to have a little cry. Just make sure that you're crying less than the family. If you're crying more than the family, we have a problem. But if you're crying a bit less, then you're just fine. It doesn't matter if you cry alongside the family. Making sure that the integrity of the parent-child relationship is intact. That's particularly important in PICU because effectively on an intensive care unit, what you're doing is you're giving your child over to the intensive care team. And then you feel like a bystander, an observer, rather than the child's parent. So making sure that that relationship is restored before the child dies. And then if this is a family who have got spiritual faith, then that's often very important to them. Thank you, Abby. Next slide. And then in terms of discussions and how we do them, make sure you've got a professional consensus before embarking. It's easier said than done, can be incredibly difficult because everyone has an opinion, particularly if there are many neurologists involved. You know, you have 3 neurologists, you probably have 4 opinions, that sort of thing. So make sure you've got a consensus before you embark on a conversation with the family. Provide information clearly. Make explicit recommendations about what is best, what's in the best interest of the child. Parents, by the way, don't like that phrase, in the child's best interest. I don't use it in front of parents. And reassure parents about ongoing care, that whatever we decide for the child, resuscitation or no resuscitation, intensive care or no intensive care, we will care for your child even after your child dies. We will always be caring for your child. And then you often just need a lot of time, and these things require a lot of time and repeated discussions often. Thank you, Abby. Next slide. And just kind of, these are just my reflections. That often these discussions may be done when the child is still well and stable, and the family are having to kind of live with this for months at a time, if not years. Parents can be both grateful and angry or demanding at the same time. They often oscillate between hope and bereavement. And that really reflects their role as advocates, really, that actually the child's death must not be a result of their inaction or failure. As a clinician, you can often feel vulnerable And it's horrible when you're always saying no to them and you have no treatment to offer. But you have to be honest. But also kind of, accept that sometimes you might get things wrong. And then we're trying to balance that against our duty to do no harm. And again, that can be difficult. Thanks, Abby. Next slide. What I find is that if you can get the patient or parents to say for themselves, but where they think the child is with their condition, that really helps. And I ask them that, where do you think little Rosie is with her condition? And sometimes they say, oh, I think she's getting tired. I'm very worried. And then then you know that you're going to be on an easy course. But at least you know where they are. I often acknowledge that actually my role as a doctor is to do the science bit and the quite hard objective bit. Their roles as parents might be different. Sometimes we just need to ride out the family's anxiety or distress or demands whilst trying to manage their expectations. Now, often the families are very reasonable, although they're kind of wanting to go, what about this trial and what about that trial, and can we try this and can we try the cannabinoids? But often they're very reasonable and very polite and respectful. But with some families, actually, it feels like it's really unreasonable when every day they're sending you a Daily Mail cutting or a link to the Telegraph or something, and you're like, oh, not another newspaper cutting. Mutual and support and consensus among clinicians are incredibly important, can be more difficult than expected, but actually that's really where your main support is as a clinician. And I find that parents, with very few exceptions, I can count on one hand maybe in the last 10 years, who never got there in the end, but actually parents always get there in the end by and large. And what they do is they recognize when the child is tired or has had enough or it's too much. Thank you, Abby. Next slide. What the advanced care plan is not is a save the date. It's not a set in stone kind of thing. Okay. I just wanted to show you the paperwork next, what an advanced care plan looks like. And this is, we'll skip the slide. This is really just saying about all the things that you've said about really. So this particular advanced care plan, although it's got the Southampton header on it, actually, if you look at the bottom, it's used by many different trusts. So about half the country uses them. I think in London, you're probably starting to trial them. I think in the north of London, some of the districts. But yeah, so the London paperwork that won't necessarily look like that, but it will contain lots of the same elements. Next slide, Abby. We'll just skim through the next slides quite quickly. So I'll just show you the important pages. The first few pages got also demographic data and things, but this is what the bit around a life-threatening event and going to intensive care looks like. And really, you kind of have a small description about what the child is likely to deteriorate from. And then we give every child support to transfer to a preferred place of care, maintain comfort and symptom management. That always is the default tick, as well as simple suctioning, mouth care, clearing the upper airway, because that's all easy to do without any distress to the child. And then the subsequent options really can be individualized to that child, whether they should be getting oxygen or not, bag mask ventilation, transfer to hospital, IV access or intraosseous access, invasive, non-invasive ventilation, and then intubation and intensive care. So you might take a yes or a no, or you might take a yes and then put a rider on it at the bottom of the page. So so the idea is that takes you through the steps of what would be escalation of treatment. Next page, please. There's a page around end-of-life care and what wishes might be, and that covers where they want to be, if there are any spiritual or cultural wishes, aspects that we might need to pay attention to, what might happen to a child's possession. So I had an 8-year-old boy who was desperate to fill out this section, and he had osteosarcoma, and he basically said he did not want his DS. I don't know what his computer game, the DS machine, that was not going to go to a 6-year-old brother. That was actually going to be buried with him. He was insistent on that. And in fact, that is what happened. He got buried with him. I'm not sure if the 6-year-old brother was more upset by the DS disappearing into the ground or his brother dying. But so it's actually, it's incredible how children can actually make their wishes known if you ask them. This page also allows us to discuss organ and tissue donation, just because it is a routine thing on this page. There are some parents who will say, no, never, forget it. And then there are some parents who go, oh, I hadn't thought he would be eligible. What would my child be eligible for with this background condition? And then I might go and find out, and the parents might be very willing to donate organs or tissues. But I have to say, having done all these plans, more parents are willing to donate than not willing. So it's worthwhile asking. And in 11 years of doing this, not one parent has been cross about me asking them. In fact, many of them are very grateful that you asked, because you would ask any other parent, any other child would be considered, why not their child? And again, some parents have thought through what their funeral preferences are, and some parents have not. So this page, you can leave blank, you can fill in all the sections, you can fill in some of the sections. It's really what the family is ready to do. Thank you, Abby. Next page. And that's just a sign off. The really important thing about this page that I want to highlight to everybody is that the parents do not have to sign it. The parents can sign it if they wish, but they don't really have to. This is not a legal document. This will not stand up in any court of law. This whole document is just a documentation of a conversation that you've had with the family and what you've agreed with the family. It is not a legal document. They can change their minds at any time. So really, it's just like your medical notes. It's not something the parents have to sign. It has to be signed by a consultant, a lead clinician. So if a registrar has had this conversation and filled out a plan, it needs to be countersigned by a consultant. But really, parents do not have to sign this. Next page. And then this is just a page with the key contacts to fill in, so that all the contact numbers of everybody involved is easily accessible. And you make sure you also give a copy of this plan to all the people involved. Thank you. Next slide. And the very last page, so that again it's easy to access, it's clear, it's at the back, is the DNA CPR page. And because we're dealing with children, not adults, they can have it. You see the middle section is a section around modified CPR, and that's because they might have a respiratory resuscitation but not a cardiac resuscitation. So which is entirely consistent with how a child would deteriorate rather than an adult. Thank you. Next page. So really just to say, for end-of-life care at home, it's delivered by community nursing team, the local pediatrician, and in our district it would be the Southampton Palliative Care team would be involved, and then hospice possibly if the child's in a hospice or known to a hospice. And then we think about all the usual things: symptom management, the practical care, out-of-hours support, and often I say to parents is, if things change, you need to know what to do for the first 30 minutes, who to call, where to turn for help. And then also we talk through some of the emotional support, what to say to the other children, how you manage uncertainty. Next page, next slide. So it's about those three things really. Symptom management should be planned in advance. You have to think about holistic management, and it's particularly around addressing the fears and anxieties of the child and family, and it's not just about the drug management. Parents need to know what to expect, how to deal with it in the first 30 minutes, and who to call for help. Next slide. And what we do is we talk through the management strategies quite early on, even before the child has had any symptoms really. And we provide written guidance. Every palliative care team I know does that. And again, we've got I'll show you a sample of the symptom management guidelines that we do. Next page. So this is just a sample to show you what it looks like. So a little bit of information about the child at the top, and then really in sections. So you have a section around pain, and then you have step 1, step 2, step 3, nausea and vomiting, step 1, step 2, step 3, and then agitation. Next slide. And then breathlessness, cough, seizures, and if you think a child might have seizures even though they never had a seizure before, so for example, this child might have brain mets but never had a seizure before, but if a seizure is possible, always make sure you've got a seizure section, that the family is warned that there might be, because seizures are very frightening to look at, and then the steps that they need to do. Next slide. And then possibly, if the child might need a continuous infusion, then a plan as well for that. And that's often for the community nurses, so they know what to expect. Next slide. And then just in terms of referring a patient to a hospice for end-of-life care, easy to tell the hospice earlier rather than later. There needs to be a nurse-to-nurse discussion and a consultant-to-consultant discussion. What we want to know is what the child might be dying of, what the parents' expectations are, what the preparations are, and what to do if the child does not die after transfer to the hospice. So we need an exit strategy. Next slide, sorry. And most hospitals will do a daytime transfer only, but for bereavement. So if you want to transfer a child after the child's died, then sometimes we will do that at night. And for hospices, siblings and parents can stay, but often not the extended family. Next slide. Yep. And that's it. So I just really wanted to then put the specific references. If you want a good reference formulary, so a drug formulary for palliative care and palliative care drugs, then the APPM, Association for Pediatric Palliative Medicine, APPM Master Formulary 2020. If you Google that phrase, it comes up as a PDF document, free to download. The next version might not be free to download, so I would download this one if I were you. Like I say, it's a PDF file, so you can download it onto your phone. It's really helpful. If you want some extra advice, it's in then look up the basic symptom control manual, and that's published by Rainbow's Hospice. Again, free to download as a PDF document online. Thank you. I'm happy to take questions if there's more time. I think we're probably up to 2 o'clock, I think.
Thank you so much, Michelle. That was a fantastic overview of palliative medicine for everyone. And does anyone have any questions they could post in the chat briefly?
No, all happy? I think you've got lots more talks coming up, haven't you?
We do. So that was a really useful overview for most of us who are general paediatricians. And we got focusing in on lots of the aspects that Michelle was talking about today. So thank you so much for that, Michelle.
That's all right, no worries. And I've emailed you the presentation anyway. There are no photographs, so feel free to distribute. I don't mind if people want copies of that talk. Like I said, I've got no photographs and no confidential information, so I don't mind if that talk gets distributed.
Lovely, thank you.
All right, thanks everybody.